Japanese colleagues and you present Professor Zannad and Professor Sato.
Okay.
Professor Sato is French, in fact.
No, it's okay.
And at least I'm very, very happy to have two top leader in the cardiovascular area that we will see in a minute, Professor Zannad and Professor Sato. Both of them, as I just said, are French. And we are going to send the passport to Professor Sato, the French passport. Okay, then we had an incredible session that was chaired by Dr. Doy and Dr. Boulanger. Thank you again for chairing that session. It was really, we learned a lot and it was just great. And I'm sure, Shiro, that we will do the same here with the session on epidemiology and mechanism of heart failure with, again, top speaker. Then it's my deep pleasure if Eiichi Akiyama is ready to start with the first presentation on why heart failure related outcomes are different between Asia and Europe. Then we will do exactly like the first session, 10 minutes presentation, 10 minutes, and then questions after each presentation. Thank you, Eiichi.
Thank you, Alex, for kind introduction. Can you hear me?
Yes.
Can you see the slide?
Yes.
I'm Eiichi Akiyama. Now I'm working at the Kawaguchi Cardiovascular and Respiratory Hospital, and I'm a cardiologist. Today I will show you our data comparing acute heart failure patients between East Asia and Europe. Thereafter, I will add some discussion using the recent data from the recent Japanese cohort data. Recent registries suggest that the characteristics of acute heart failure patients may differ between Asia and Europe, though direct comparison of mortality between acute heart failure patients and Western countries in real world practice is scarce. The primary objective of the present study was to assess the effect of geographic regions, specifically East Asia and Europe, on 1 year all-cause mortality in patients presenting with HF in our great registry. We used the Japanese, Korea, and China as East Asia, and France, Spain, Italy, Switzerland, Finland, and Czech Republic as Europe. Primary outcome was the all-cause mortality at 1 year. This slide shows the patient characteristics. Acute heart failure patient from East Asia was younger and more likely to be female and had lower body mass index and lower prevalence of heart failure with reduced ejection fraction compared with patients from Europe. And acute failure patients from East Asia has a lower prevalence of the history of heart failure, coronary artery disease, atrial fibrillation, and the non-cardiovascular comorbidities such as diabetes, hypertension, and COPD. Levels of creatinine, sodium, and hemoglobin were relatively similar between East Asia and Europe. BNP levels were slightly lower in East Asia compared with Europe. Hospital length of stay was much longer in East Asia compared with Europe. Medication at discharge were prescribed more in Europe compared with East Asia, such as beta blocker, SOIRBs, and MRAs. 1 year all-cause mortality was significantly lower in East Asia compared with Europe. Unadjusted hazard ratio was 0.52. Even after adjustment or propensity score matching analysis, 1 year all-cause mortality remained lower in East Asia compared with Europe. This slide shows the result of subgroup analysis. In all studies subgroup analysis, the result was consistent. Interestingly, Japan, Korea, and China have the similar 1 year all-cause mortality, though Czech Republic has a higher one-year mortality compared with other Western Europe countries. In summary, HF patients from East Asia had 50% lower in lower one-year-old cause mortality compared with those from Europe. Why are heart failure outcomes different between Asia and Europe? Mechanisms remain not fully understood so far, but there are several explanations has been proposed. Of course, the ethnic or genomic differences, environmental, social, economic variations, differences in healthcare systems, and natural life expectancy all may affect the result. This is a data from the JROD DPC registry in Japan, investigating the population association between population density and in-hospital mortality. Patients from higher population density area has lower in-hospital mortality compared to patients from lower population density area, which may suggest that people living in densely populated area may easily access the more advanced medical services. Indeed, in Korea and Japan, population density is much higher than European countries and China. Life expectancy may different. Japan and Korea has the longer life expectancy compared with Europe or China, though the Western Europe countries with high income have the similar life expectancy compared with Japan and Korea. How about acute heart failure management during hospital stay? This slide shows the usage of intravenous heart failure therapy. Acute heart failure patients receive less inotropes and more vasodilators in Japan compared with Korea and Europe. Vasodilators administered in the 78% in Japan. It will decrease in recent days. Hospital length of stay was much longer in East Asia and Europe, East Asia compared with Europe, specifically in Japan and China. Intentional longer hospital length of stay in China and Japan may influence outcome in HF patients. This is a result from the wet heart failure registry, comparing the investigating the association with the length of stay and short-term composite outcome. Patients with shorter length of stay and much longer hospital stay was associated with the higher composite endpoint. This study may indicate that around 2 weeks length of stay may be best in Japanese situation. And moreover, what are Japanese cardiologists doing during long hospital stay? One answer may be the cardiac rehabilitation. Cardiac rehabilitation during hospital stay was performed in 50% of HF patients, and the median days of cardiac rehabilitation was 11 days. Patients with cardiac rehabilitation was older and higher prevalence of ICU stay compared with without cardiac rehabilitation. However, patients with cardiac rehabilitation have lower in-hospital mortality and comparable short-term post-discharge outcome. Another possibility is that in-hospital coronary angiography. This shows the result of optimized heart failure from United States. In United States, only 8% patients of acute heart failure underwent into hospital angiography, despite the higher burden of coronary artery disease in United States. This is the result of our Japanese reality HF cohort. In-hospital coronary angiography was performed in 38% of acute heart failure patients. And the CH group showed much lower 1-year all-cause mortality compared with non-CH group, even after propensity score matching. Length of hospital stay was longer in CH group compared with non-CH group, despite the magic risk score is lower in CH group compared with non-CH group, which may indicate a lower risk profile in CH group compared with non-CH group. And beta blockers, aspirin, and statin were prescribed more in coronary CH group compared with non-CH group. Acute heart failure management in Japan comprises longer lengths of hospital stay, along with longer in-hospital cardiac rehabilitation, coronary angiography, and extended use of GDMT. Thank you for attention.
Thank you very much, Eiichi. I see that you have really very exciting data. Maybe if you can stop the sharing the screen, then we can see whether there are questions, if you don't mind.
Yeah.
Thank you so much. But again, bravo for the data. I see that you are using propensity score matching and other ways to analyze data, and your data were really beautiful. Who would like to start with some questions to Eiichi? He did really a nice presentation showing that really there are ways to go. And by the way, I don't know if Eiichi, if Shiro will say it, but we just got some plasma from Japan, from acute heart failure, and the analysis, I'm telling you, this guy, the analysis of the biomarkers will be ready the next week. And I think we will see whether biomarkers will be different between acute heart failure in Japan and acute heart failure in France. Any question for Eiichi?
Can I try one question?
Yeah, Faiez and then Shiro. Faiez?
Yes, I really appreciate the presentation. It's very clear, but it's most focused on acute heart failure, whether the differences in chronic heart failure and whether it is in HFrEF, in HFpEF, are also striking as strikers in acute heart failure. This is my question, because I believe that acute heart failure outcomes are very much dependent on the healthcare system and the length of hospitalization. So maybe in chronic stable heart failure, there are fewer differences. Is that correct assumption?
I don't know exact data about the comparison of the chronic heart failure patients between Asia and Europe. It may be.
Eiichi, maybe what Professor Zannad is saying, maybe you should try to collect data on chronic heart failure, HFpEF, REF from Japan. With Faiez, we have data on chronic heart failure in Europe, and then we could do a paper showing that there is no difference, but there is a proposal here to do some interesting work.
Yeah, the suggestion is that acute heart failure is so much heavily dependent on the healthcare system, with threshold of admitting patient, the length of stay, which are critical. In chronic, there are less of such an issue, and you may wish to tease that out.
Plus, you can see
important comment.
You can see differences in the use of beta blocker, ACE inhibitor, etc. Then I think there is way here to go for it.
Yeah, medication.
Shiro.
Yeah. Thank you so much for a great presentation. I have one question because you analyzed the patient who had coronary angiography and not. I don't think coronary angiography has impact on mortality itself. So why the patient who had coronary angiography has better outcomes? I don't think CAG itself has no impact.
Yeah, that's an important. Thank you for your important question. Yeah, and the result of CAG or the coronary intervention is not associated with outcome in our cohort. So not only for CAG, the test for the reason for the decreased cardiac function is important, and I will show. I showed the GDMT was prescribed more in CAG group compared with other groups. So the medication is also important. The GDMT implementation is also important.
Okay, you mean
not
so
only
in
for
Japan,
the
So you mean in Japan we have a lot of time to prescribe GDMT, right? Is it the problem? I think.
Do you mean the?
日本語でいいですか?
In our cohort, the GDMT is prescribed more in Europe compared with in Japan. So, but the half-twelve is preserved ejection fraction is more in Japan compared with Europe. So so it may differ.
Is there other questions? No, if not, Shiro, I give you the floor.
Okay. Okay. Can I move on?
Yes.
Okay. The next speaker will be Professor Faiez Zannad. He's really very famous. We know very well, and he's the top leader of acute heart failure and chronic heart failure. And his presentation will be differences in drug trials results between Europe and Asia. So please, Professor Zannad.
Yes, thank you so much. And I'm really pleased to follow on the Dr. Akiyama presentation, because these are very much relevant to each other. Whether there are differences in drug trials results between Europe and Asia, the quick answer is that there are, but there are really inconsistent, and we don't know how to do with them. So that's the short answer. But trying to elaborate on this, I would like to start to show that indeed the contribution of Asia to trials is increasing fastest. Just as a reminder, in 1987, the first ever randomized trial with enalapril, the consensus trial, was done only in 3 countries, and these were Nordic countries. Now, the latest trial, Paradigm HF, Commander HF, Emperor, etc., on average, there are 30 to 50 countries in these trials. So the regional country geographical differences are really relevant to discuss. And Asian countries' contribution is growing fastest in the latest trial. So this is a very important and timely question. Now, in order to tease out whether there are differences among the continents and geography, you need to really be careful. And this follows the question I just asked to Dr. Akiyama. You need to compare carrots to carrots and not the apples to carrots. You need to compare chronic to chronic, acute to acute, registry to registry, and trial to trial data. And I've just taken extreme cases here, a very large, important registry trial in chronic heart failure, the report HF, and in acute heart failure trial, right? And you can see that the results are totally different. There is some reason. The reason is methodology. So we need really to be careful comparing things which are comparable. And you can see the mortality in heart failure was highest in Asia Pacific, as we have heard early on, but this is a trial of acute heart failure. But if you get to the chronic heart failure registry, there's nothing special about Southeast Asia, at least. The mortality was similar to the other continents. So if we take this further, I'm trying to move forward and compare the characteristics of patients now. Well, very expectedly, there are large differences in characteristics of patients in Asia versus other countries. And usually it's mostly related to sociocultural and medical practice backgrounds. There are potentially genetic differences, but in heart failure, nobody has come up yet with any specific genetic traits which may influence the effect of drugs. It's mainly sociocultural norms of aging, health belief, receptivity to medical intervention, and very importantly, as we have heard from Dr. Akiyama, length of stay. And this is, again, healthcare system organization and social cultural. And if you compare now trials to trials, acute, inacute, chronic PEF, and chronic REF, I will save you the pain of going through all these numbers and get to the simple conclusion. There is simply nothing special with Asian patients' characteristics. Asian patient characteristics are extremely similar to any heart failure patient in the globe, whether it's an acute, PEF, or REF. Characteristic, right? Baseline. Now, if you take the Paragon heart failure trial, we did find a number of differences, and these were found to be mainly related to the differences in hospitalization practices, which are actually independent from region and differences and from comorbidity. And this is, again, a key factor. Hospitalization practices, whether it is the threshold which a general physician would decide to rush a patient to the hospital, or the duration, length of stay, and therefore it has a very important influence, as discussed on the earlier discussion, on optimization of guideline medical therapy as well. Now, the acute heart failure trial, ASCEND-HF, within the trial, has tried to tease out the importance of level of income, which is a great surrogate to healthcare organization. And more than level of income, I will share with you the inequalities in income. I will come to that later, but just the level of income, if you classify countries across the globe, depending on whether they're high, upper middle, or lower middle income, there are really very important differences, not only in the trial conduct. You can see in higher income, there are low rates of protocol completion, higher rates of adverse events, similar mortality rates. But if you adjust for race, geographical region, clinical factors, and then you will find really that higher income have worse clinical outcomes. It's all the other way around, and higher rates of hospitalization. So level of income becomes really important. And within Asia, this paper we have contributed with Karen Lam groups show very clearly that the level of income is really critical on the rate of hospitalization. And this is true across the globe, but it's also true within Asia. So it's more than the position of a country on the map, geography, region, it's basically level of income. And we have suggested in this paper that future trials should not do the subgroupings across the countries by country or position in the map, but rather by the level of income. And actually more so than level of income, it's inequalities of income. And there is a great index called the Gini index. And we have used that in this analysis across 3 different trials here of MRA, emphasis, and of the DPP-4 inhibitor in diabetes. And guess what? The highest contributor to the outcome is this factor, which takes into account high inequality and low income. It's stronger to predict outcome than age, than renal function, than atrial fibrillation, than diabetes, and then myocardial function, much stronger. So healthcare organization, which is reflected by high inequality and low income is probably the most important factor contributing to regional differences. Now, we have also published the result of emperor-reduced, and wondering whether it is the Asians who are the outliers or other countries. Just to show you that here, we did find that in Asia, we have indeed, we have indeed an important rate of outcome, the highest outcomes in the placebo group here, that was true. But what happened when we have seen the effect of medication, we have seen that across two trials, the DAPA-HF and emperor-reduced, and this is the meta-analysis we've published, the outlier were not Asia, it was Europe. Asia, Latin America, and North America results were very consistent across the two trials and across the globe. But it was Europeans which hardly benefited from this treatment. And this is really a big question mark. We don't know why. And this was statistically significant. P for interaction was statistically significant. So we tried to see whether this is related to ethnicity, although there is an ethnic mix in all countries, maybe less in Asia. Well, again, we found that the white patient benefited less than Asian and Black. So the figure is really complex, and I will almost done with my presentation. It's not only the position of the country in the map, it's mainly healthcare organization and inequality and level of income, but there may be also some ethnic influences. And in order to know more, because the short answer to the question which I addressed today is whether there are differences, the answer is we don't know. And we don't know because we haven't done a good job collecting data. And we haven't done a good job collecting data because the Asian colleagues are not contributing much, but this is mainly related to the organization of health industry. We have contributed this paper, published not so far long ago, on the leadership, trial leadership across the globe. And you can see in Asia, there is hardly less than 5% of trial leaders and trial collaborators as compared to Europe and North America. So everything we know about trials is coming from North America and Europe. Hopefully the increasing rate of organization of trials in Asia, but also the increasing leadership, and I would like you to take the leadership of trials, will help us know more about this issue. Thank you so much for your attention.
Thank you so much for your great presentations. Is there any questions?
If I may share, I have one question.
Yeah.
Yes, first, thank you very much, Faiez, for your presentation. I have two questions. I guess one for you and even Eiichi. We often maybe wrongly put Asia together. And do you think inside Asia, are there differences? And my next question would be if you can maybe define a little bit better what you mentioned earlier, the inequality.
Yes, the answer to the putting Asia together is it is wrong practice. Asian is very diverse region, ethnically, populationally, level of income and healthcare organization. But that's true for every other country. It doesn't make sense to put Africa, Middle East together. There are the rich, Middle East and the poorest, Sub-Saharan Africa. It doesn't make sense to put all Europe together. There are large differences between Eastern and newer low level of income. And therefore, and this is our suggestion, we need to get away from the subgrouping based on geographies. We really, and the most influential factors in these global trials we found is indeed the level of income. And to answer your second question, inequalities in income, it means the range of the highest and lowest income. And there is an index called the Gini index, which show whether the wealth is distributed across all the population. And of course, you may guess that United States have a very high level of income, but it ranks very low in equality in income. There is highest inequality as well. So the inequality is much more important than level of income. You can be a rich country, but if the wealth is not equally distributed, then the healthcare system is suffering. And among the highest countries with high level of income and high equality is Western Europe, for example. And there is a very large heterogeneity within Asia, because Japan is high level, high equality of income, but Malaysia may be middle, but it's very high inequality of income. Same for Singapore. So it's really important to take care of this ranking rather than, because this is the best indicator of the organization of the healthcare system and how health is provided to all citizens.
Okay, one question from the floor. Professor Shibagaki, please.
Yes, thank you very much. And thank you for your presentation, Dr. Zannad. But my question is that I think that the income level is not necessarily proportional to healthcare level. I mean, how does income level have something to do with the real world healthcare, health management? And is it healthcare cost or educations, or do you have any comments on that?
Yeah, well, again, it's more than the distribution of income and then the absolute number of income. And the right example is the United States. They have a very high level of income, but very low level of equality, so a large inequality. And it is health insurance. If you are rich in the United States, you have good health coverage and you can afford paying for any healthcare, and including medication, right? Just to take an example, sacubitril valsartan monthly cost is $400 a month, right? And 80 million Americans have no health insurance. And therefore they will simply not afford this medication. They will not take it. That's the extreme example. And it goes similar for the hospitalization. If you have a whole good health coverage, you can access to the hospital immediately and the best possible hospital. If not, you go to public hospital, and maybe you cannot afford to have, high cost healthcare. So this is the main reason. It is the distribution of income, which is related to out-of-pocket money, which in France, for example, out-of-pocket money is 5 to 10%, right? In countries with no health insurance, it can go up to 60 to 70%. And 60-70% of the cost of hospitalization can get you, you spend all your money. We call it the catastrophic expenses. The catastrophic expenses is how many families in the country can go bankrupt just paying for their health care. And in some countries where the distribution of wealth is very low, this can go up to 10-15% every year of families who may just go bankrupt because they have put all their money to save their daddy or their mother or whatever. So that's really important.
But my question is that related to what we can do about it. I mean,
I'm afraid it's not us, it's politicians. And you are really touching upon a very important issue. We are doing our job as doctors, but the health system and implementation of the results of trials, etc., are so much dependent on politicians and the social fabric that maybe you and me should do some politics and stop doing only medicine, because our progresses are not necessarily implemented because of other factors just than healthcare.
Thank you very much.
Okay.
Professor Sato.
Can I have a quick question? Thank you very much and a nice presentation, Professor Zannad. I have just quick question. And how about the genomic differences in between Asia and Western country? Yeah, and environmental income is we cannot control, but if we can find some differences and genomic differences between Western country and the Asian country, if you have any data, and
Sure.
please explain.
That's really important question. Every thing I've seen in heart failure, certainly, and it's overall also correct in most of the most frequent cardiovascular diseases, shows that genetic differences do not explain much in heart failure and cardiovascular. There are very few genetic variants which has a strong enough influence that it may influence the benefit of a medication. And whenever it has been looked at, no major difference was found out actually, really. So there may be rare diseases or, you know, some genetic penetration diseases where this may be different, but into multifactorial and with the very little contribution of genetics like heart failure, there are unlikely that the effect of medication and the difference in trials may be explained by genetics. Most of the time, these are other factors than genetics. So maybe I will get wrong. In some time, we will find some, but as for now, nothing really important emerged in this genetic difference. Now, in other important, we didn't really discuss it, in the doses of medication. I know in Japan, you are really very much focused on using lower doses on the principle that the volume of distribution is lower or any other factor. But I must say that anytime we have checked this, it didn't turn out to be true. And the recent trials, Japan patient took exactly the same dose than the other parts of the world, and it went well, and there was no higher rate of adverse events. So I don't know how much the difference in pharmacokinetics or in tolerance of the highest dose is really different. And this is an issue you and me should address together, because I know the Japan Food and Drug Administration, the regulators, insist to see a separate set of patients in Japan. And this has actually very much helped the participation of Japan in global trials, which is great news. And therefore, we do have data now from patients contributing to big trials. And so far, we haven't really found any specific difference in patient in Japan or in behavior or side effects or efficacy.
Okay, thank you.
Thank you so much. And so let's, there's no questions. Okay, so let's move on to the next step, presenter.
And what I hear from you, since later we are going to have the representative of the two embassies, the Japanese embassies in France and the representation of the French embassy in Japan, we will insist to say that we need to collaborate more and have more Japan being really the leader of trials, because as Faiez was showing earlier, if the leader of the trials is Japanese, then there are a lot of centers in Japan who include patients, and Japan learns more. It's my pleasure to introduce Dr. Hideo Tokuyama, that I met in Japan a few years ago. And again, in this session, Epidemiology and Mechanism of Heart Failure, he'll talk about ischemia. Thank you, Dr. Tokuyama.
Can you hear me? Okay.
Yes, yes.
Oh, sorry.
If you can go full screen, it's better. If not, it's okay like this.
Okay, let's start. Sorry. My name is Hideo Tokuyama. I'm working in cardiovascular and respiratory hospital. I'm specialized in catheter intervention. Today, my theme is ischemia. As you know, heart failure have a variety of cause and risk factors. Ischemic heart disease is one of the most important etiology of heart failure. This figure shows ischemic heart disease mortality rates over time. As for Japan and France, the mortality is estimated in low level compared with other countries. In developed countries, the age standardized mortality rate tend to be falling. But due to aging, the crude death rate remains unchanged or is increasing slightly. Especially in Japan, population is estimated to be shrinking and aging at the same time. Because of this, the number of heart failure patients is expected to increase. That is why it's called heart failure pandemic in Japan. This figure shows the etiology of heart failure in Asia. Chart 1, its blue line represents 2000 to 2004, and chart 2, its red and orange line represents 2006 to 2010. The percentage of coronary artery disease as an etiology of heart failure is significantly increased. Also, it's same situation in Europe. This is the ESC heart failure pilot date. In this survey, the percentage of ischemic etiology is around 50%. Recent studies reported that the population of ischemic etiology is high in Europe compared to Japan. We will have to see patients with ischemic heart failure more and more in near future. As shown in this figure, it's known ischemic heart failure has poor prognosis. Additionally, it's in the same way regardless of preserved EF or reduced EF. In this paper, as for reduced EF, ischemic heart failure was worse than idiopathic dilated. Because of poor prognosis, the management of ischemic heart failure is challenging. I think there are 4 key points in that management: cardiac function, ischemia, arrhythmia, and risk factor control. From 2019 ESC guideline, the concept of chronic coronary syndrome was suggested instead of stable coronary artery disease. Chronic coronary syndrome is generally classified into 6 clinical scenarios. Ischemic heart failure is, of course, included in chronic coronary syndromes. The guideline emphasizes it's important to prevent further cardiovascular events such as death and myocardial infarction by controlled lifestyle, medical therapy, and appreciate coronary revascularization. To prevent from developing to ACS is significant because ACS may acutely destabilize each of clinical scenarios. I'd like to show focus on ACS. This chart indicates the proportion of CLIP classification with AMI patients in Tokyo, Japan. About 75% patients were classified as CLIP 1. They usually have good outcomes. However, about 10% were in CLIP 4. Most of them were in cardiogenic shock. Another observational study reported that in AMI patients, 4.6% were in cardiogenic shock. These patients have poor outcomes, and its in-hospital mortality rate reaches over 30%. We can use a new device and medical treatments such as new generation drug-eluting stent and latest antiplatelet therapy, but the prognosis in AMI cardiogenic shock has not been improved last 10 years. Recently, Impera is available for treatment of AMI cardiogenic shock. It's a new mechanical circulatory support device, and in October 2019, it was launched in Japan. The principle of the Impera allow for direct unloading of the left ventricular from the inflow and increase mean atrial pressure and flow in the out from the outflow of the device. Impera enable to unload the left ventricular by reducing the left ventricular and diastolic pressures and volumes. Impera has been expected to have better outcome in AMI cardiogenic shock. It's against the background of the result of IABP shock to trial. The study reported that the use of IABP did not significantly reduce 30-day mortality in patients with cardiogenic shock, complicating AMI, for whom an early revascularization strategy was planned. As a result, the use of routine IABP is not recommended and classified as class 3 in both ESC and JCS guidelines. Impera should be considered in cardiogenic shock as short-time MCS, and it was classified class 2A in ESC guideline. On the other hand, in JCS guidelines, the recommendation level of Impera has not been differed. The efficacy of Impera for hemodynamic status is obvious. Above all, the concept of LV unloading is one of the most expected good effects in AMI. The figure is a study in dogs. The study reported that LV mechanical unloading by the support of Impera during the acute phase of myocardial infarction reduced infarct site and prevented subsequent heart failure in dogs. The volume of infarct site reduced by 52% in partial support and by 87% in the total support of Impera. It is considered that the reduction of infarct size by Impera support is due to control of reperfusion injury. The door-to unloading stem pilot study demonstrated that compared to LV unloading and immediate reperfusion, LV unloading and delayed reperfusion for 30 minutes does not increase infarct size. And among patients with some ST elevation 6 millimeter or more, infarct size normalized to the area at risk was significantly lower with 30 minutes of LV unloading before reperfusion compared to LV unloading and immediate reperfusion. Thus, appropriate timing of implanting Impera is pre-PCI as soon as possible. The concept in MI treatment is changing from door-to-balloon time to door-to unloading time. I will share JP-WAD registry. It's multi-center prospective observational all-comer registry data in Japan from October 2017 to January 2020. The number of cases is 823. Endpoints are patient characteristics, 30-day survival from initiation of Impera support, and safety profiles, including all adverse events. This is the reason for Impera indications. 45% were in AMI cardiogenic shock. As for support duration, the median duration of Impera 2.5 and Impera CP was about 5 days. The proportion of Impera 2.5 was high in this registry. However, as introduction of Impera CP, Impera 2.5 was rarely used. This is a result of the study. Impera support showed favorable survival rate at 30 days compared to the previous report of VA ECMO support. Concerning AMI cardiogenic shock, Impera supports also showed favorable 30-day survival. Impera is variable unique device, but Impera is still developing, not much user-friendly. And to make use of Impera, learning curve is needed. We often have a chance of adverse events. Hemolysis, bleeding, and peripheral ischemia were 3 major adverse events in Impera. In this study, the rate of major adverse events were reaching acceptable ranges. Finally, I'd like to show some cases briefly. The patient is a 56-year-old male. Impera CP was implanted due to AMI cardiogenic shock and refractory ventricular fibrillation. In this case, carpet region was LAD segment 6. Coronary flow reperfusion could be achieved just by Impera therapies. Next patient is 80-year-old male. Similarly, Impera CP enabled coronary decanalization. That indicated Impera pump flow significant increase in coronary flow. Last case, the patient is 69-year-old male. He was managed by VA ECMO and Impera CP due to AMI cardiogenic shock. It's called Epidemiology management. Epidemiology makes it possible to collapse of LV and reduce LV-BDP and LV-BDP. It leads to decrease in myocardial oxygen demand. That is total unloading. That's right. In conclusion, the number of ischemic heart failure will increase in developed countries. Progress of ischemic heart failure has not been satisfied. A prognosis of ischemic heart failure has not been satisfied. Concept of chronic coronary syndrome was proposed. Prevention from developing to an ACS or further cardiovascular event was emphasized. Among ACS, the complication of AMI cardiogenic shock has poor outcome. Impera is a unique mechanical cardiac support device and may have potential to bring better outcome in AMI cardiogenic shock. Thank you.
Thank you so much. Are there any questions for this very nice presentation? I'm really impressed by the Japanese database with the Impella. It's really a very large, maybe one of the largest in the world. Really, it's impressive. Any questions? I may start. Dr. Tokuyama, concerning your big registry with Impella, I think it's more than 100 of centers. Is it correct?
More than 100. 100 cited, yes.
Yeah.
It's correct.
I have 2 questions. One, do you have centers that are putting much more devices than others? And would you see differences in outcome among those who are very active compared maybe those who are less active? And my next question for later is hemolysis. 11 hemolysis. How in Japan, how do you speak about hemolysis, and how because it's true all around the world, but this is one of the major issue of mechanical support is hemolysis and bleeding. But first, do you see differences among centers in Japan?
Okay, thank you for your question. So the Impera is a very unique device, and the management of Impera, we needed to learning curve. So the constitution of using Impera is selected, and the Impera, whether Impera is working or not for patient, it depends on patient. So the university hospital and advanced hospital, I think implant is needed. But implant is developing device, so the adverse events, there are adverse events such as hemorrhages. So the
徳山先生、日本語で、
はい
たくさんインペラ入れてるところと、
はい、
あんまり入れてないところで、横に差はあ
下
る
がるかってことですよね。
うん
その横に差があるかっていうところまではデータはないですけれども、その
Yeah, I think it is, let me additional answer, because I'm one of the investigator of the JPBOD and the Impela group. So I think it is already Tokuyama told you, and learning curve is really important, but it's no differences, so far no differences between institute. Is a big center, is a small center, so far it's no difference. But each institute is learning curve. And the first 5 or 10, and the patient is lots of complication, and bleeding, infection, hemolysis, but then getting better in each institute.
Yeah, this is a very important information, and if you are going to have a paper, it's important to mention this, that there is a similar learning curve, if there are differences or not, because in Europe, indeed, people are using Impella and showing a lot of interesting results, but now there is a lot of meetings, including in the US and Europe, only on complications, how to reduce complications. Okay, other questions? Maybe another.
Can I one quick question?
Yes, Naoki, indeed.
So I just interested in how much in the using in the French. In Japan right now, in the 200 institute, and need to license to use an impella, and use the number of the impella that's getting increased. But how about in the French?
Yeah, the number is increasing. We are, in fact, a lot, because there is a French tradition, or at least a French experience. You may have seen with our paper that we published the last year in Lancet Respiratory Disease, this year, sorry, in Lancet Respiratory Disease. We have a paper that just came out with Mattia Arrigo as the first author, and Pascal Le Prince is a co-author, and we have a long tradition in France to put VV ECMO, indeed in RDS, COVID, etc., and a VA ECMO for cardiogenic shock. And really, it's a long tradition of VA ECMO. Recently, although VA ECMO is used in ICU, we have since 5-6 years, we are using Impella in the cath lab. Today, it's really specifically put in the cath lab in, I would say, few centers around the country. It's really increasing. And there is a big trial financed by the health minister with Laurent Bonello from Marseilles, who is the PI. And probably this will bring us a lot of data on efficacy and safety. The trial should start in a few days, including several hundred of patients. Okay, Shiro, would you like to introduce the last speaker, please?
Okay. Our last speaker will Professor Naoki Sato. He's a top leader in acute heart failure and chronic heart failure in Japan and all over the world. So let's move on his presentation. Professor Sato, please.
Okay, thank you, Shiro. And can you see my slide?
Yes.
Yes.
Okay, so my theme is congestion. And as you know, and a congestion is the main reason for hospitalization in a patient with AHF. But we still do not understand exactly about congestion. I would like to give you a quick summary about congestion at present. So first, what is congestion? And maybe a French physician knows, and him and Dr. Jean-Nicolas and Cobsot, a very interesting 200 years ago, already he described 3 stages of a heart failure. And the first stage, breathlessness and exhaustion without any physical finding. And the second stage, ankle edema and breathlessness at rest. And finally, third stage, end stage, and coldness of extremity and liver enlargement. And based on Dr. Kosa's concept and in clinical setting, we can evaluate 3 types of the congestion, that is pulmonary edema and fluid retention and low perfusion. And another classification, and congestion can be likened to an iceberg, and it can be considered as above sea level and below the sea level, and the clinical congestion and the hemodynamic congestion. And furthermore, we can summarize and congestion from a neurohumoral aspect, that is a sodium retention, mainly due to activation of renin-angiotensin outburst system and class 2 activation of the sympathetic nervous system. On the other hand, water retention due to mainly vasopressin system. So, and the 2 major retention of systemic and organ congestion. One is sodium retention, it's another one, the water retention. So I think it is from this concept, we need 2 kinds of diuretics, and natriuretic diuretics and aqualytic diuretics. I think it is very reasonable. And I want to introduce a new concept in congestion. I took it from the Nature Review, and one of the authors, Professor Zannad, and it's really interesting and concept, tissue congestion and intravascular congestion. And the tissue congestion is normal state, hydrostatic pressure and equal oncotic pressure is interstitial space is nothing happen. But and the compensatory mechanism maintain and the compensated heart failure, but in decompensated state and fluid start and build up in the interstitial space, and the GAG network, it is no longer bound together, and the increased water volume in the interstitial fluid. So, and next I want to talk about an assessment and congestion. And first, let me talk about universal definition and the classification and heart failure, and provided by an American Heart Failure Society, ESC, and the Japanese Heart Failure Society. Here is a universal definition, and symptom and signs very important, and also we have to check the natriuretic peptide level and objective evidence of cardio, pulmonary, and systemic congestion. Symptoms, already as you know, and the typical factor, we have to check this, and the signs, more specific, and this factor we have to check to evaluate in the congestion. And also we have to measure the NP level and supporting definition with heart failure, BNP more than 100 and T-proBNP more than 300. And as you know, T-proBNP and BNP is a good risk marker predictor. And we summarize and usefulness of the NT-proBNP at admission more than 5,000 is really high risk. And during hospitalization, if we can reduce NT-proBNP levels as more than 30%, it's a better prognosis. And after discharge in a cutoff level 1,000, if patient has a more than 1,000 level, is poor prognosis. And also we need another biomarker. And the Professor Zannad already published several papers and solved CD146. I really interested in this marker, and we need some other congestion marker. But right now, they're not common use. And the statement recommend an object evidence of the congestion using some modality. Let me summarize. One is radiographic congestion. This paper is recently published, but as you know, and the chest X-ray is low sensitive, because if the congestion is very slowly, the chest X-ray like this, but rapidly we can evaluate and congestion using a chest X-ray. But the most important thing is, and the modality is ultrasound approach. Of course, you can check the cardiac function, and the lung is really important. But the JVD and the renal venous Doppler, I think it is very limited use, and it's not common. And also lung congestion detection by impedance, and this is best. And this is a monitoring and lung impedance. And if we can detect in the worsening lung condition, give a treatment and avoid the hospitalization. And also, and the pulmonary artery monitoring is really effective. It's already, as you know, champion trial and suggest and this monitoring improved outcome, and other study and also and reduced heart failure hospitalization and reduced all-cause mortality. But we cannot just do one condition marker. We have to build some score. And let me introduce two in the condition score. One is and Professor George Heidi suggests, and with ESC and ESICM, and this score, and also PNAIR, JVP, and edema, and BNP, and exercise. Another condition score recently published in the European Journal of Heart Failure and provided by HF Association with ESC, and almost same, and JVP and also PNAIR and the NP, X-ray, and vena cava image lung ultrasound. But this score is not common, and maybe we need some standardized and congestion score. As finally, I want to talk about initial treatment and briefly. And this is an aim of the acute heart failure management and by Japanese heart failure guidelines. Its most important things is improve the congestion. It's not improved outcome, I guess. And how to improve the congestion. And the guidelines suggest we have to use a clinical scenario and also Stevenson classification and start any treatment and depend on the major physiological condition. And the timing is very important. And also reassessment is really important because in a past physiological condition is dramatically changing, we have to modify the treatment. This flowchart came from the statement and how to use the diuretics. And this flowchart combined pulmonary edema and systemic edema, just use diuretics. But recently we suggest in the flowchart management divided pulmonary congestion and systemic congestion and low perfusion. For the pulmonary congestion, we have to use NPPV and a vasodilator. And then if not enough, and sometimes we add diuretics. But its main pathophysiological condition is a systemic condition. In that case, we have to use diuretics first. And the loop diuretics, low dose loop diuretics is not enough. We should add tolvaptan because aqualesis is a control extracellular and intracellular both. But natural urealysis is just intravascular and congestion. So let me summarize in the scheme. And natural urealysis is the reduced intravascular volume, but is not extracellular volume. In contrast, aqualesis decrease in intra and extracellular volume, and that keep the intravascular congestion. That's why aqualesis do not decrease in blood pressure. And we evaluate using impedance system device and the tolvaptan and furosemide and improved intracellular, extracellular water volume, but just give the furosemide, just extracellular and water volume is quite different. So let me summarize. Evaluation of congestion is still we have to evaluate the symptom and the sign and the supporting biomarker, but so far is BNP and T-proBNP is common, but we need another novel marker to evaluate in congestion and also modality and the standardized congestion score. This is it's really important. And also goal of the acute phase, improve the congestion and the perfusion and initiate organ protection treatment as early as possible. Thank you for your attention.
Okay, thank you so much for your great presentation. So now we are open discussion. Do you have any questions?
Can I start with one question?
Yeah, please.
Thank you very much, Naoki, for your presentation. Japan is probably one of the countries where congestion is the best studied. For years, you are really the lead on explaining congestion. And I think you are lucky to have a tolvaptan also. We heard earlier that the patient in Japan after acute heart failure will stay for long periods in the hospitals. Your resident and your fellow, do they check the level of congestion every 2 or 3 days and make sure that congestion is resolved before the patient goes back home, or congestion is not necessarily followed every 2 or 3 days in the hospital?
Yeah, I think the most of the cardiologists check the congestion and before discharge. And most of Japanese heart failure patients at admission know orthopnea, and it's really improved the peripheral edema. Sometimes it's a little bit, and still the patient has peripheral edema, but it's no orthopnea and no pulmonary edema. Maybe, and Dr. Akiyama can answer because he is every day and treating a heart failure patient. Am I correct?
Eiichi, what do you think?
Yeah, I checked the peripheral edema and neck pain. what's every day?
Did you see Eiichi and Naoki? Did you see a paper? There is a paper that just came out a few days ago showing that jugular vein distension is the best parameter of congestion. Did you see this paper? They compared clinical signs and Swan-Ganz, and the only relationship, good relationship, was jugular vein distension and right atrial pressure, but no relationship between wedge pressure and pulmonary edema. The best is jugular vein distension. Then Eiichi, you're right. We should keep measuring jugular vein.
I will check that paper.
Yeah, I can send it.
Yeah, and related that question. Recently, I educated a patient in how to evaluate JVP. Yeah, they can learn. It's amazing. Yeah, so if that way, I think it is a patient himself and herself and prevent hospitalization with a heart failure.
Yeah, this is very interesting because it's maybe easier, you know, with the COVID, now we are trying to have patients taking care of their own heart failure disease at home. Since it's difficult to have natriuretic peptide at home, maybe you're right. Maybe they should look every day or every other day on jugular vein distension. And maybe there is a study to be done, but clearly the patient can benefit of learning how to measure it. Pierre-Louis, do you have a question? Yeah, we don't hear you.
Very nice. Thank you so much for this brilliant presentation. I was wondering whether there are imaging studies that would enable us to assess tissue congestion. Yeah, are there specific MRI sequences or tracers, PET scan tracers, or something like that that might be tried to see this microvascular leakage in tissues?
Yeah, I think it is very important. And if I'm correct, in the related RNA study and using the MRI, evaluate extracellular volume. So maybe, but it's not easy. So maybe, and if we can do that way, and but the acute phase we cannot. So that's the big problem. So that's why we need some congestion biomarker. Yeah, I think it is a CD146, and it's really interesting. And what's going on in that biomarker in Alex?
But we keep measuring it, and as I told you, I hope in the next weeks we will measure CD146 in the Japanese biobank and the French biobank, and then we will see the differences. It would be very interesting to see how different are the congestion among them.
Interesting.
Yeah. Then if you agree, we are going, if there is no additional questions, we are going to stop here. If you don't mind, we would like to do a picture now of the screen and all the participants, and then we will go to a break for the next 10 minutes. And then the jury, Professor Sylvestre, Professor Shibagaki, Professor Samuel, and Professor Lenoir will be present. We will hear the two winners of the competition named Young Fellow on stage. And after hearing the two presentations, we will have a conclusion by the representative of the two embassies. But in the meanwhile, if you don't mind, can you turn on your camera? All? Can you all turn on the camera? Venez ici, là. And Carole? Ah, il faut qu'on reste là. Okay. Then, okay, then I was stupid apparently.
Non, vous voulez nous prendre en photo?
Yeah, yeah. Okay, then I need to explain in French because my Japanese is not so good. Then if you can turn on your camera and we are going to have a nice qui j'ai donné ma caméra.
Mon ami
Ok. Vous prenez avec les deux, vous faites ça et puis vous faites ça. Ok. Alors, is it good enough?
Et je prends l'écran aussi.
Oui, oui, alors oui, c'est ça, sinon on ne vous demande pas. Il faut quelqu'un qui a fait des études.
Non, mais on peut avoir tout le monde, ça peut être facile.
Yeah. Eiichi, can you resolve your tie, please, a little bit? Yeah, perfect.
Vous arrivez à voir l'écran et tout le monde?
Do you see everything?
Je reprends.
Yeah, remove the mask then, just for the.